tough topic. Unless you master the previous Figo, like all of us have it on our tip, you will not understand the new concept. When you have a complicated topic, always you fall in line to the expert. And I was honored that the author and the best scientist who actually presided over and wrote happens to be my great friend and always willing to teach students. So, what better way? One line I sent, and then she immediately told, yes, take my word, this is honor. People travel across the world to Hong Kong, US, UK, Europe to listen to her. You are luckiest it has come to your doorstep. Please take full opportunity of this. It's my honor and pleasure to invite Professor Dr. Neerja Bhatla, Professor and Head of Department, Gynae Onco Department, AIMS. More than that, she is the one who is the flag bearer of India across the world. You know that the whole East used to look to West, but now the whole story is different. The whole West is looking to East, and one of the reason in the field of gynecology and Gynae Onco is because of Professor Dr. Neerja Bhatla. Very passionate about this subject, very passionate on this. It is your honor, fantastic orator, and she is the author. Please, after this talk, download and read the article she has presided over in this staging line to understand, then go back and revisit this. Thank you very much, Neerja, for accepting our invitation. We are honored, indebted. Welcome, over to you.
Thank you very much, Dr. Somashekar. It is such a generous introduction, and I hope that I will come to the expectations of your trainees. And I'm truly impressed to know how many of them there are. It is a wonderful thing because really we have a huge unmet challenge in this country of managing the malignancies, which are increasing every day. So, without spending any more time, I will go on to the topic of the day on the recent changes in the Figo staging in gynec malignancies, what and why. And we will talk, as Dr. Som said, about the features of the staging system, as well as the carcinoma cervix revision, which came in 2018, and the carcinoma vulva revision, which is more recent of last year to 2021. Now, why do we do staging? We do it to describe the extent of the disease. This helps us to plan the treatment. It also predicts the prognosis. By this method, we can evaluate the treatment response not only of our center between time periods, between other centers and us, and we can also guide the appropriate research. If we look at the history of the Figo cancer staging system, we see that it went back almost a century ago when in 1928 this concept was first developed, and this task was assigned to the Radiological Subcommission of the Health Organization of the League of Nations. As you know, the League of Nations was the predecessor of the United Nations. And in 1929, we had the classification, but they were still working on it, and almost a decade passed as they tried to make the Atlas on cervical cancer staging and first recorded the changes. But then the World War came and everything got pushed aside till 1950 when the international classification was developed, and it was in 58 that Figo became the first official patron of this annual report. I am telling you this whole genesis to tell you why Figo has the ownership of the gynec cancer staging, because it was the first one to come before AJCC, before UICC even. And it was, in fact, the first staging of any cancer was the staging of carcinoma cervix. And subsequently, the latest revision, of course, is 2018. Then there was staging for carcinoma vulva, which came next from 1969. Then came the staging for carcinoma endometrium, ovary, and so on. And the staging for GTN was actually only at the turn of this staging. Now, it's very important that these staging systems should be applicable in different resource settings so that they are universal. And these skills required for the staging should be achievable, the investigations should be affordable, and they should aid considerably in the management. The good staging systems, of course, there are very complicated ones now, as you know, which have come, for example, for breast cancer. But really, a good staging system, if it is simple and it is reliable and practical, it becomes something for postgraduates, something that can be used at the periphery. It is something that can be used. You don't need a computer to generate a staging. And so it must be valid, it must be flexible, it must be non-ambiguous. When I took over as the chair of the Figo Cervical Cancer Committee, and this is a meeting we organized in Pune on the sidelines of a Foxy Figo conference, we first started thinking about revising the staging at that time, and it in 2015, and it finally came out in 2018. And I would like you to note down not just this one, as Dr. Somashekar said, you have to read the original, but also the corrigendum, which came out soon thereafter, and it has some minor changes to it, minor but important, and we will talk about them. So please make a note of both of these articles. Of course, when you open the first one, you do see the button which says updates, and you can go immediately to the final table. So, what were the drawbacks of the cervical cancer staging which required it to be considered for a revision? So, the clinical staging which we used to do, and we used to do it because cervical cancer is a disease of the poorer countries, because there are limitations to the access to radiology and pathology. So it was decided to remain clinical for a much longer time. Endometrial and ovarian initially were also clinical, but went to surgical path. But here, the limitations were that it would not detect accurately the tumor volume, the parametrial involvement, the lymph node involvement, most importantly. Most importantly, the lymph nodes could not be seen, and when found positive at surgery, they did not change the stage, even though we knew that this is now a very poor prognostic factor. If there are para-aortic nodes involved, then it's worse than just the pelvic nodes involved, and so on. Now, because of the inadequate preoperative assessment, many patients would receive multimodal therapy, and also to some extent that you're not changing staging contributed to this decision. So you have done the radical surgery and then you send the patient to radiotherapy. That means that they are going to have even worse side effects now. And so while you may not see the mortality curves changing, but there are severe implications for morbidity. Now, this also means that there is inappropriate use of resources in already resource constrained conditions. If you look at the population and you see how many people are wanting treatment, then it is not appropriate to focus double resources on any one patient. Now, in the last decade, significant improvements occurred in imaging and minimally invasive surgical techniques. In India, we know that in spite of being a resource constrained country, once the patients are reaching to the cities, there is a lot of access. But there are many parts of the globe, in Africa, etc., where that is not the case, even in the best cities. So as I mentioned, that the function of a staging system is to be able to show you these diverging survival curves. That is the most important thing that we should be able to see, that the curves show there is a difference in the survivals as we go from the stage and as we go by the years. And this was there, of course, even with the clinical system. Yet there was even up to a 40% error rate. And without cross-sectional imaging, a poor evaluation of deep pelvic invasion. The accuracy in the early stages is better, even 85%, and the later stages is poorer, it is 21%. So the reason being this, which we mentioned about the tumor volume and the nodal mets, but also stromal invasion, lower uterine segment involvement, these do not get reflected. And if we have to look at the further research, it is inadequate data to help that when based only on clinical staging. These are again some of the studies which have been around for a long time, which are showing the prognostic value of nodal mets, the GOG study, which looked at para-aortic node status and pelvic node status and found it to be significantly associated with PFS. Again, they looked at the tumor size and they found it to be significantly associated with the PFS. And imaging, of course, we have for a long time stopped doing a routine procedures like cystoscopy and proctoscopy when there is no sign of local extension particularly. And this can help us to identify several of the important prognostic factors, the volume, the lymph nodes, upstage or downstage disease, and therefore these less side effects that we discussed. And if we look at the incidence of cancer cervix through the world, we can see that there are the sub-Saharan Africa, Asia, South America are the places which are particularly disadvantaged. And the main thing to note is that in spite of that, it's not that it is only these regions which do not have the adequate imaging. This can be a function even of the better so-called countries, even if you see in the OECD countries. And if you look in Africa, of course, they don't have radiologists, they don't have pathologists. So it's a difficult task that we were faced with, that we have to make amendments that will suit all these countries. But, and I have to say to you that it was, in fact, at that point, a very difficult situation that if we do not make a staging that takes these things into account, there will be a breakaway of the developed countries to make their own staging system what they were threatening to do, which would have been terrible to have two different stagings for two different resource conditions. And that was the reason why we came into this situation where you can use, as you have the capability, the clinical, the radiological, the histological, and then you have to specify what you are doing. So in the amendments that we have now, in addition to the physical examination, the information from imaging and surgical histology is taken into account. It can be any imaging modality. Figo is not prescriptive about that, but it should be readily available, and this should not lead to a delay in the treatment. Because you have a waiting for MRI doesn't mean that you will not proceed with the treatment. And even pelvic ultrasound can be used, MRI can be used, CT, PET MRI, whatever you want to use. But it should not be the use, again, it is recommended, of multiple imagings for the same patient. Choose and optimize the imagings. The histopathological findings obtained from the surgical specimen will be used to upstage and supersede all other findings. This is a question I'm frequently given even now, that if there is an imaging and there is a pathology, no, there is no doubt about it. The pathology overrides everything else. The tumor size has been classified in this staging into 3 subgroups, and the pelvic nodes, if positive, go to a new stage called 3C1, and the para-aortic go to 3C2. So the 3C stage was a completely new stage. Now, if we look at the differences between the Figo 2009 and the 2018 staging, and you can see that there are some studies in the last column which tell you what is the sort of justification or basis, you may say, for these changes. So one thing was that in stage 1A, we have removed the lateral spread of the lesion as being a factor, because this is something where there was not really any convincing evidence on its relationship with the incidence of lymph node metastasis. And there was also limited guidance on measuring the horizontal spread. And therefore, we have removed this, although there was some outcry from the pathologists that this was not something to be done. And you can see that the correlation is there of the rate of lymph node positivity between the depth that is there. So, you know, I had received a lot of comments, as I told you, it was 3 years between the first thinking to the last, and a lot of people would say, I feel this should be, and I feel that should be, based on experience. But, you know, that's not how it works. It is only published data that can be taken into account. So I would strongly recommend to each one of you to get into the habit of data keeping, data recording, data analysis, and data publication. Because eventually, when future stagings come, there will be your data will be used in that, and that will apply to whichever field you are in, whichever cancer you are working on. It is the published data that will guide the future development, and it is part of ethics that we must do it and publish it. Now, coming to stage 1B, you can see that we have made this division. The 1B1 has been subdivided into 1B1 and 1B2 at a cutoff of 2 centimeters. This is one of the changes in the corrigendum. Previously, we had put at less than 2, and here was more than equal to, and we have changed that in the corrigendum to this. So here, this was based on a lot of data, which I will show you some of those studies, which came from trachelectomy data mainly to show how the survival changed when the tumor size was less than 2 centimeters versus how it was more than 2 centimeters. And therefore, this cutoff has now enabled a better discrimination, as well as it gives a guidance to people who are starting out with doing these type of procedures. And now in the context of MIS also, there is a great discussion on how the tumors which are 1B1 less than 2 centimeters may be all right to do it by MIS. Particularly, people are trying strategies like doing conization prior to the procedure and so on. So there are various ways in which it has evolved and how it will be used in the future to guide the further research, the further development. So this is some of the data I mentioned to you, the vaginal radical trachelectomy data. This one came from Canada, from Mary Plante, showing how there were most of the recurrences and the deaths were in those with the lesion size more than 2 centimeters. Only 10% of patients had lesions more than 2 centimeters, but they represented 50% of the recurrences. Similar data from the Danish, similar data from Korea, and so on. So the final stage now is to be assigned after you have received all the reports. So it becomes whether it is an imaging based or whether it is pathology based, depending on the stage that it is. And the method you have used is to be noted. So if it is clinical, it has no notation. If it is imaging, it has an R notation. And if it is pathological, it has a P notation. So stage 2, broadly, nothing has changed. It remains the same. The only thing is that you could use imaging to make this diagnosis. And of course, the pathological specimen may change your stage. And this is the one where we have now stage 3. The 3A and the 3B remain unchanged. The 3C1 is there, which is because there is a change in this. Of course, this Matsuo study I will show you later. This is not what was based on, but what has come out later. Now, very important it is to understand the concept of isolated tumor cells and micrometastasis. So these, in the initial staging, what we had proposed the correction, we had said these will not change the the staging. Although we did have, I have to say, the AJCC and UICC were very much on board with us in developing this staging system. But in the subsequent, just almost immediately after publishing the staging, there were a lot of differences of opinion on this, and they said that micrometastasis, there are enough reports to suggest that there is an impact on prognosis, just as macrometastasis, micro being less than 2 millimeter. So that was moved. That is the second change, which you will see in the corrigendum, that micrometastases do change the stage. We do consider them as positive. The isolated tumor cells, ITCs, we do not consider them to change the stage, but we recommend that it should be noted and reported so as to inform the future stagings. So now the stage 3C, we mentioned about 3C1 for pelvic, 3C2 for para-aortic, but it is not a homogeneous stage. And this is the main thing that we are now faced with, and which is going to be the subject of future evaluations and research, because we see that the survival of 3C1 in retrospective analysis, again, I will show you some of these studies, differs based on the tumor size. So within 3C1, you see that the 5-year survival rates differ considerably depending on the size of the tumor. And so it is a moot question why this is the case, because why does a smaller tumor metastasize? You would normally actually not necessarily expect this outcome. It could be a more aggressive tumor, which even with a smaller size has metastasized to the lymph node. But here in this retrospective analysis, we do find that if they were smaller, even if they went to the lymph node, they did better. And this may be related to their response to the radiation or to the surgery or whatever it may be. So this requires a prospective evaluation to really confirm that this is the case. And once we have prospective studies, then we will be able to tell better how to keep this diverse group, how to further stage or how to change that staging. So these are some of the studies that were reviewed at the time when this staging was being done. For example, which type of imaging should be done? Does it matter? Is it MRI? Is it CT? It is lymphangiography. In fact, they were found to perform similarly in the detection of lymph node metastasis. Similarly, if you look at MRI versus CT versus PET, here there were 41 studies with histological confirmation looked at here. And while the PET or PET-CT had an overall higher diagnostic performance than CT or MRI in detecting metastatic lymph nodes in patients with cervical cancer, but it was not something which was completely self-evident, and therefore there is no clear recommendation. And of course, we know that MRI gives a better delineation of the soft tissues. So to the extent of looking for the tumor size is possibly a very good way to stay with. This was a study which showed the lymph node staging by PET in relation to the prognosis, and you can see that there is a clear disparity between no lymph node involvement, pelvic lymph node involvement, para-aortic lymph node involvement, and supraclavicular if you look at the disease-specific survival probabilities. And so it is, this is clear that the lymph nodes do make a difference. And again, if you're looking here stage-wise, even within each stage, mostly it is a very clear correlation. So this again is similar data from other studies. And very importantly, what I mentioned about the sonography, which we do not probably tend to take it so seriously, but in sonography, it is the man behind the machine which makes all the difference. So it can be very subjective. And these data are coming from Europe, which show that a high resolution TVS done well, and it compares very, very well with the MRI, and it can be a consideration. Again, here you see the diagnostic accuracy is very comparable. And the other one which has been looked at is transrectal, which is got one advantage that it probably, especially with a little bit of a bigger tumor, it may go up in the rectum and get a better delineation, as well as sometimes you could have some bleeding from the tumor by the contact with the transvaginal probe, which would be obviated in the rectal. But having said that, we did our own study. One of our MCH candidates did a study, and we did not see this to be too much of a problem. And it does require an additional probe. So this is to be decided on an individual basis what you would prefer, but all these options are valid. In fact, even 3D transvaginal tomographic ultrasound imaging has been studied and it has been found to be a good option. But of course, this is again very sophisticated imaging. And so this I'm showing you for the sake of completion. But obviously, if you have to do that, you might as well do an MRI. So this surgical-pathological assessment of lymph nodes requires advanced surgical skills. There's no doubt about that. And I can tell you that it is in fact in many places quite the rule that they will not give extended field radiation for the para-aortic nodes unless they have confirmed that there is a uh, involvement. So there was the practice which was going on and is still going on in many places, is to do an MIS lymph node pickup and see whether positive or not. Also the radio give the radiation. So the imaging can be used in some situations where this practice is not there or this facility is not there, whichever the case may be. But the discrimination between malignancy and inflammation has been left at the discretion of the clinician, because you know that there can be a lot of problem in areas which are have a lot of tuberculosis, a lot of HIV, where nodes may be enlarged without being malignant really, and especially in the kind of regions where CA cervix is more prominent, these are serious problems. So it does leave something open at the discretion of the clinician. If you decide that this node you think is positive, you will label it as a 3CR. And if you decide that this node is not and you go ahead with the surgery, then you will have the pathology to guide you, and then your staging will be assigned based on the P. So that is the way this staging works. But the recommendation is that the best available technology should be used and the lowest attributable stage should be assigned. And the method, as I said, R or P should be noted. So some controversial issues still remain: the assessment of lymph nodes by the radiological method, the tumor size in the largest dimension, but should we rather be looking at the 3D of it? Now, the ovarian and lower uterine segment do not change the stage. Having said that, I would say that you should see that there is a retrospective analysis which was done by Dr. Kailash Narayan, and some others have also reported the same, that once there is involvement of ovaries, there tends to be, and the lower uterine segment, there tends to be more of lymph node positivity. So in any case, many of these patients are moving to stage 3C. So these are things where there is not enough evidence on their impact on the outcome survival. So therefore, these things still remain and they will be addressed once there is more data about it. The impact of this staging has been on all the people who are stakeholders in this. And as I said, once any staging comes out, there's typically an outburst of publications to look at the revised staging and to see how they get redistributed. And this is the paper I was mentioning by Kailash Narayan. Please take a picture of these and you can go into each of them and read them in detail. In fact, De Gregorio showed that there was a change in more than 55%. Now, a lot of these were simply because the tumor size was causing the change of stage, but a lot of them, a third of them, were because the lymph node was changing the stage. And I mentioned this one before of Matsuo to show you the slides on how the 5-year survival curves are changing, and the quantum of increase in risk that is seen. And the stage 3C1 was independently associated with improved cause specific survival compared to the stage 3A or the stage 3B disease. But as we have seen, it was broken down by the tumor size. Being a heterogeneous group, where the local tumor factors, in addition to the nodal status, are important determinants of survival. So these are the various studies that are there. I think we should not dwell too much on these right now because we should leave some time for questions, but you can go into these and see that what is the type of situation, and you can look at your own data and see. So now I am going to come to the CA vulva staging revision, and this has been done by Alexander Olawai, in fact, also a very good friend of Dr. Somashekar's, and he is from Pittsburgh. And this was the committee at the time when he did this. It was, in fact, Sean Kehoe, you see him here. He was the chair after I was, and it was in his term that Alex has done this. It was very, very interesting. This is the article that there was. Now, you know, the Figo 2009 staging of CA vulva was quite complicated. It was based mostly on a review of retrospective studies, and it was lacking in prognostic capability. Now, I've already shown you how with the CA cervix staging, we had this outpouring of studies looking at their own data. This has happened in the past also. In CA endometrium, they removed the impact of cytology. Peritoneal cytology does not change the stage any longer, and there was suddenly an outpouring of studies showing the impact on prognosis or decision making or whatever. So in this case, the CA vulva was a completely new concept. It was designed to look at existing data and to apply it already and then go on. So the old staging, we had majority of data, retrospective, single and multi-institutional, and the 10-year course specific survivals were similar for stages 1 and 2. And I'm repeatedly explaining that this is not good. The staging system should show the separation of the curves in terms of survival. So in this new staging, we prospectively collected data and did part of it, of course, not prospectively necessarily created, but also took at the data from the SEER database. And it was the most evidence-driven staging revision ever undertaken by Figo. And we hope that the findings are generalizable because they've looked at a large database. So this was the United States National Cancer Database, which was looked at. These were all the committee members who participated in it. And they reviewed the literature, of course. The analysis of data collected between 2010 and 2017 were looked at. Many tumor characteristics were collected for all the stages of vulvar cancer that had been treated at this time. And this statistical analysis looked at the OS based on tumor characteristics and grouped those characteristics which had similar survival together into stages and substages, and then analyzed whether each higher stage carries a worse prognosis than the preceding stage or substage. So this is the situation now. The 12,063 cases that have been looked at in this database. If you see, the minimum number is actually stage 4A, which is 70 cases, but all the others are around at least the 500, 600, 700, 800, and the stage 1B is the largest with the 7,600. But you can see that here now the 5-year survival has been very neatly organized into descending mode in that sense. And you can see the impact on the median survival as well. So these are the curves that have been generated out of this, showing this clear divergence. And this is how it compares the old and the new. And in this case now, the basement membrane of the deepest adjacent dysplastic rete ridge, or the deepest dysplastic rete peg to the deepest point of invasion, is to be taken in measurement, because this has been shown to be correlating better with the treatment outcome and with the development of recurrences and the disease-specific survivals. And if we look at the description of stage 1, we see that there is no change in criteria. It is just a change in the methodology for measuring the depth of invasion. And if we look at stage 2, there is no change in this stage. If we look at stage 3, it now includes the upper 2/3 of the urethra, vagina, the bladder mucosa or rectal mucosa, which were previously stage 4A, any number of lymph nodes as long as they are up to 5 millimeters, and no longer includes that category of lymph node mets in a single node more than 5, because that used to be a very difficult and complicated one. That now goes to stage 3B, and stage 3B has any number of lymph nodes more than 5 mm and 3 or more lymph nodes if size was less than 5 mm, which used to be a criterion, has now been excluded, and that goes down to 3A. In 3C, there is no change. The stage 4A has excluded the upper 2/3 of urethra and vagina, this bladder mucosa rectal. Now these are in stage 3A, as we discussed. And so this now allows incorporation of cross-sectional imaging findings into vulvar staging, similar to cervical cancer. So you can use the imaging and pathology the same way. The same ITCs do not count as lymph node mets, and lymph node positivity reflects the consensus of cervical cancer staging, which is the micro and the macro metastases are considered as lymph node positive. Documentation regarding the HPV status is recommended. HPV associated or HPV independent, as you know, up to 40% of the vulvar cancers may have HPV. The exact impact of this on their outcomes is not as clearly known yet as it is for the oropharyngeal. So this is something which we have to collect the data going forward, and it is recommended to be used for all the morphological types of vulvar cancer except the melanoma. So to close this section about the staging of CA cervix and CA vulva, I want to impress upon you that the staging classifications are dynamic and responsive to emerging data on the impact of new diagnostic techniques. The demonstrable evidence of a survival benefit between stages is important. The impact of new modalities, surgical and otherwise, on outcomes is also taken cognizance of, and systematic collection and publication of data is of vital importance to influence future revisions. So with that, I thank you for your patient hearing, and I close this slideshow. And if there are questions on this, I would be happy to take them. Otherwise, I can also show some slides about the CA endometrium, if you wish.
Yeah, Neerja, please show them. Still we have time, lot of time.
Yeah.
Yes.
So just to take a little bit of shift now from this CA cervix and vulva and look at carcinoma endometrium, which is such a upcoming, I should say, field. And recently, one of the students, NB students, has got has been commended also for her thesis work on this subject. And so I'm not going to dwell too much on all of this. I'm going to concentrate a little bit more on the aspect which is likely to change the staging. So as you may be all aware that the molecular classifications of CA endometrium have come, and there was a lot of interest when I was chairing and in the 3 years when I was the past chair to change the CA endometrium staging to the molecular. But it was definitely agreed, and rightly so, that the time is not yet ripe. These things are not universally available or applicable, but the time will come. And this is important to now start collecting. We know, of course, that it is something which is increasing now. CA endometrium is increasing. Part of it is probably the lifestyle changes. A lot of our senior AGOI members were involved in preparing this consensus document, which I had the privilege of editing for ICMR, and I would encourage you to go into um, this and get it from the website about this. So I don't want to dwell on this. Of course, a little bit for the sake of students is always good to know the old dualistic model, which we have been going with, the Bachmann classification for so long, defining them as type 1 and type 2. And it's good to know that these have the precursor lesions also, which are clearly identified, and they do have some mutations which are specific to the type 1 and the type 2. But this is not what I really want to talk in this limited time right now. I want to talk more about the Cancer Genome Atlas Research Network, the TCGA, report about the comprehensive genomic and transcriptomic analysis of endometrial cancers. It has been categorized into 4 genomic classes: the poorly ultra mutated, the microsatellite unstable, the MSI, that is hypermutated, the copy number low, which is endometrioid, and the copy number high, which is the serous-like tumors. So this is how that whole genome analysis has divided the mutation spectra across the endometrial cancers. And you can see these 4 categories are clearly defined over here with the mutation numbers and all the various other factors of their classifications as well. And you can see here how this can be divided by looking into each of these sequentially, and how you get finally, sort of excluding them into the 4 different categories. And this is how the PFS curves look for the 4 of them. And you can see that the worst outcome is with the copy number high, and you can see that the best outcome here, which you are seeing for the poly tumors. So this is a very, very important discovery, I might call it, which has brought about this whole thinking on how it should be done. And if there is one slide in which we can categorize it, then this is it, where you can see the summary of the TCGA molecular types, and you can see the molecular features across the 4 types, the histological features, which are also different to an extent, and a good pathologist might be able to tell you something about it. But it is the diagnostic tests on the various mutants that is the one which becomes a very interesting situation, which becomes variable across the 4 types of groups that we have here. And the clinical features are very clear: the younger age at the poly, the Lynch syndrome for the MMR deficient, the advanced stage in the P53 mutants, and the higher BMI in the NSMP tumors. The prognosis is similarly variable. It is excellent for the poly ultra mutated. And here you may consider now going forward the data emerging to say that this is a group where maybe you spare them the chemo and radiation, give them maybe immunotherapy. In the MMR deficient, it is intermediate, sensitive to radiation, and you can give immunotherapy for the metastatic disease. But the P53 have a poor outcome. They benefit from CT in combination with RT, and the NSMP have an intermediate to excellent prognosis, and they respond to hormonal therapy. So it is not a theoretical only, it has real implications for how you are going to guide your outcomes. So these are these molecular classifications, the Leiden Transportec molecular classification. And this is the way the Vancouver group has suggested that you take the sample, you do the MMR, and you see if it is missing unclassifiable impact. Okay, wait on MMR deficient clearly identified. Once it is intact, then you see if the poly missing, unclassifiable, poly mutated, go out there. The wild type, you further do the P53. The P53 IIIC missing is unclassifiable, but otherwise you decide which category it goes into. So the pathologists have an immense role to play over here. Of course, with the precursor lesions also, this old WHO histological classification, and we always worried about the ones with atypia, where even up to a third of them might be harboring already the cancers. But now the simple and complex, this classification is removed. Now this is what we look at: hyperplasia without atypia. It's a less than 1% chance that they are harboring anything sinister. But if it's an atypical hyperplasia or an endometrial intraepithelial neoplasia, then up to 3%, up to 33% risk that there is a coexistent invasive, 25 to 33% risk. And the progression to invasive carcinoma has a 14 to 45 times relative risk. So now this is not exactly what I want to dwell on over here, but yes, the use of hysteroscopy to some extent is required, and it does, if it does not change the stage, you know that. And there are some hysteroscopic morphological patterns also which are there, but then this is really more about the we wanted to see about see. But here the MIS one take home message is that this is the difference from CA cervix, that this is the standard of care for early stage, the laparoscopic, the robotic, ideally suited, and especially for those women who have a high BMI. It's just fantastic. And it is to be recommended that everybody gets skills in MIS for endometrial cancer. This is about the lymphadenectomy. And here, this is the recommendations that are based on the ESMO consensus conference on endometrial cancer. And this is one article that everybody really should read, because it is a very, very well written and very clear. And the take home message is really about the lymphadenectomy role, which is now tailored. And if the growth is more than 2 centimeters, involving outer half of myometrium, moderately or poorly differentiated, high risk histological subtype with the cervical or adnexal involvement, and enlarged nodes. Now here, actually, the sentinel nodes have a very important role to play, because although we say that the more than 2 centimeter size of growth, and yet I will say, because you all are NB students, I will just say to you that it has been often seen that in the obese women, they may have very large growths which are filling the cavity, but the depth of invasion may be less than half, and in fact may be very minimal. And so even with large growths, their sentinel nodes turn out negative. They probably don't need a full lymphadenectomy, and that's where the MSKCC type of model works very well. So just to present to you the standard recommendation of the ESCO 2020 consensus, as well as the possibility that there will be some of your patients who may quite benefit from not having a complete. So the SLN is the paradigm shift, which is very, very good. And you need a pathologist to be with you in this, because the ultra staging is what determines the SLN effectivity to detect the micromets, to detect the ITCs, etc. So not really that I want to go right now into the SLN, but yes, these are the various trials. But just coming back to the risk stratification and the impact that you have with the adjuvant therapies based on the low risk groups that are therefore defined, and how the molecular classification of the PORTEC-3 trial for high risk endometrial cancers, sorry, and the impact on prognosis and benefit from adjuvant therapy. In about 660 patients were analyzed in this trial, and out of these, 423 had the tissue available for the molecular analysis. So they have looked at the categories of the P53, the pole mutated MMRD and NSMP, and you can see that this is the percentage that were contributed. And you can see the 5-year DFS in the CRT group, in the RT group, and therefore they have gone on now in the evaluation of the pilot phase of the POTEC 4A trial to determine the adjuvant radiotherapy. The hypothesis being that if you base it on this molecular integrated risk profile, you'll get similar local control and recurrence-free survival as the current standard adjuvant brachy in these patients, and it will spare many of the patients. So that is what is now going on, and this is the situation about immunotherapy, where FDA has approved the pembrolizumab, which is targeting the PD-1 for patients with MSI or MMR deficient solid tumors, including endometrial cancer. And pembro plus lenvatinib have been approved by FDA for the advanced endometrial cancer that is not the MSIH or the MMR deficient, and who have disease progression following the prior systemic therapy, but they are not the candidates for curative surgery or radiation. So then it is approved to try these immunotherapies. So, well, with that, I am going to stop here with the formal presentation. Oh yes, this I will recommend to you, the Figo cancer report, which we bring out every 3 years. And I will strongly recommend to you to see. And in fact, you know, in each of the Figo cancer report, there's updating the first 6 chapters on all the cancers, but the other chapters are variable. So in fact, I would recommend to go back into the older ones as well. And Dr. Somashekhar's chapter over there is one of the most highly downloaded. I think they said it is the one which is the most highly downloaded ever. So please do look at the Figo cancer report as well. So thank you very much for this patient hearing, and I will now look into the chat box and see what that has.
Thank you, Neerja. That's lovely. So there are some questions both in chat box as well as Q&A.
So in case of stage 3C1, is it required to include para-aortic nodes in radiation field? So no, that is not required. Am I still sharing my screen?
No, we are able to see you directly.
Right. So so no, we should not, in stage 3C1, we should not include the para-aortic nodes in the radiation field, because as you know, if we go all the way up, there is a lot of side effects for the bowel and as well as for the vertebrae, and the impact subsequently on her hemoglobin, etc. So that is not really required. Now, the second question I'm seeing here, I'm seeing the Q&A, and there is also a chat box.
Yeah, there are questions both. Some students have put in Q&A, some have put in chat. So you have to open both and answer.
So I'm only seeing the Q&A, but that's okay. Let's see these first. So the patient underwent TH plus BSO. The histopath was endometrioid grade 2, and the PET 3 months ago showed reactive nodes and the need for surgical staging. So, you know, these are the questions which are constantly coming up in various groups also to ask, because the restaging of any cancer, as you know, is not an easy process for the patient. But I think it would be important to also look at the various other parameters apart from only the grade of the tumor. If we could also look at what was the size of the tumor, what was the MRI report if she had preoperatively, and what that suggested. And then we can take a conscious decision about whether we have to do the restaging. And even if we have to do the restaging, we can seriously consider whether we must do it by a laparotomy, or whether you can do it by the laparoscopy as well, because it is not necessarily a standard that you will do the laparoscopy, but it is some option which is there for some patients as well. So a tumor size not mentioned and involving the inner half, he says. So I think these are the situations where you have to have an honest discussion with the patient And you have to tell them that in the absence of a complete surgical staging, there may be gaps. So, and you have to assess also what is the risk of surgery, what is the BMI, what is the going to be her post-operative outcomes. And in some cases, if they are candidates for an adjuvant therapy, we do not want to have situations which are going to delay those. So we have to see and make a total decision. There's another question I'm seeing about best method to assess. No, I think I'm seeing the last one first. Okay, one sec here. In CA cervix, size of node is not included, no. But when they are more than 10 mm, then we think that they are likely positive. Is there any data regarding size of lymph node guiding for future investigation like PET scans? So yes, when it is more than 10 mm, we think that they may be positive. And but that whether it will guide the PET scan, I'm not sure that that is the case. And if on imaging we have no lymph node involvement, and if we find suspicious pelvic nodes, should we proceed with surgery? So I'm guessing that you have proceeded with the surgery, and you opened and you found suspicious nodes, and do you proceed with radical hysterectomy? So the ideal situation here is to be able to send them to frozen section. And if the frozen section shows them to be positive, then we should abandon the surgery and we should send them directly to uh, chemoradiation. In this scenario, should we do sampling of para-aortic? Surely we can do the sampling of para-aortic and send them to frozen section. Best method to assess for parametrial assessment in CA cervix is a very good question. In fact, as I mentioned about our study where we compared in Dr. Amit Mandal's thesis for this MRI transrectal ultrasound, we found that the clinical estimation does remain valid in many cases for parametrium more than it does for any other parameter. So if you have an MRI, it is a good method because we know it's good for soft tissues. Having said that, when there is a large tumor or when there is infection, and infection is common in cervical tumors because of the milieu that they are in, there seemed to be an impact on the assessment of both the parametrium and the vaginal extent. So again, there is no one right solution here, but I would say that clinical assessment of parametrium is still a very, very important thing to do. So if difference on clinical examination and imaging, what will be best considered to put into staging? So in clinical examination and imaging, there is not a firm decision. It's not like pathology. Pathology overrides everything, but imaging does not override clinical. Imaging, you have to decide what you are going to do. If you accept the imaging, you put that case. But if you think, no, my clinical examination is sound, and I don't think this parametrium positivity I have to see. Having said that, there are certain features on the MRI which are quite decisive. If you see that the ring is broken very conclusively, then definitely that suggests that there is involvement in the parametrium. But sometimes there are streaking, etc., which is suggestive of only inflammatory change, and that is not important. So micromets, as I said, are those metastases which are measuring less than 2 millimeters in size. So once they are more than 2 millimeters in size, they are macromets. So when they are micromets, they also do affect the prognosis, and therefore micromets are considered as positive nodes. And your take on radical hysterectomy in endometrial cancer, and how do you practice radical hysterectomy in endometrial cancer? So in endometrial cancer, it is typically the type 1 that we are doing, which is an extrafacial hysterectomy. And the question that is the most important is, what do you do when it is extending to the cervix, and do you make it a type 3, or do you make it a type 2? And that is a little bit variable because you do not necessarily need to make it a type 3. These patients will need adjuvant anyway, and most often a type 2 would suffice. But again, there is no one hard and fast for any of things. So I think we answered the question on the parametrium already. So I think that's all the questions we have, right, Dr. Somashekar? Can I say over to you?
Thank you very much, Neerja. That has been very, very lovely. This shows the questions are keep pouring, how important this particular topic is. Thank you very much for doing such a beautiful work. And heartfelt thanks from students, me and DNB board and NBM for having accepted the invitation. Thank you very much. Over to you, Navneet Singh ji.
Thank you very much, Professor Dr. Neerja, for the presentation, and thank you very much, Professor Dr. Somashekar, for joining us. And thank you, trainees and faculty members, for joining us.
Thank you. Have a nice day.